Good afternoon, everyone. I think it's probably time to get started with the afternoon sessions. Hope everyone enjoyed lunch. I'm Donna Skorchuk, class of 93, and I'll be bringing people onto stage and doing little brief introductions. Our first speaker this afternoon is Karen Shaw. Her talk is entitled Professionalism in a Changing World. Karen is a proud alumni of the University of Saskatchewan. She graduated with a BSc Advanced in 1978 and then an MD in 1983. After completing an internship at St. Paul's Hospital in Saskatoon, she practiced family medicine in a private clinic and then at the Student Health Center on campus. She entered the world of medical administration, serving as a counselor for the College of Physicians and Surgeons and later as its president. She joined the college as a complaints manager, became the deputy registrar in 2001, and the registrar in 2011. But she says she still misses family practice, and after what we just discussed, probably even more so now. I'd like everyone to welcome Karen Shaw and her talk entitled Professionalism in a Changing World. Karen?
Okay, thank you. Thank you very much, Donna. Thank you, guys. This will not be as interesting as Joe's talk. I should warn you of that already. One of the things I didn't do was to put a slide up there with conflict. I don't have anything to disclose to you. I don't think I'm in conflict. And I don't think I'm even in conflict with the college because the hours I've been putting in, I think it's a volunteer job at the moment. So professionalism in a changing world, the objectives, I just wanted to go over some key values and behaviors in medical professionalism and identify some of the factors that are impacting professionalism in medicine today and to identify some opportunities to strengthen professionalism. So what is it? It's interesting that you read a lot of literature. There's no common understanding of exactly what it is. There's lots of different explanations, definitions. Different groups have used the words differently for different purposes. And some even have gone as far to say it's easy to recognize but difficult to define, much like pornography. It's hard to define, but you sure know it when you see it. So one of the things I often do is when I don't understand something, I go back to the roots of it. So in this case, we'd have to go back to the roots of what is the nature of a profession. So this is a very busy slide, but if you look at the bolded words, it sort of gives you a sense of what we're talking about. So a profession is an occupation whose core elements is work based on mastery of a complex body of knowledge and skills. It's a vocation in which knowledge of some of the department of science or learning or practice of an art founded upon it is used in the service of others. Its members profess a commitment to competence, integrity, morality, altruism, and the promotion of public good within their domain. These commitments form the basis of a social contract between the profession and society, which return grants the profession the right to autonomy in practice and the privilege of self-regulation. Professions and their members are accountable to those service and to society. The other thing I often do is go back and look at the historical perspectives. And you can go back and have a look at the development of ethics in patient care. And there's two main pathways. There's the bioethics, which was influenced by philosophy, theology, and law. And it focuses on rights and principles. And they use problem-based cases to work through things. And it's influenced clinical practice through the application of these bioethical theory. The other stream is the professional ethics. And its precepts that underline this pathway are centered on the integrity of the individual clinician. And this is often documented in the form of professional codes. Again, from the historical perspective, you can see that way back in 2000 BC, through the times of Aristotle and the Hippocratic Oath, there was these codes that were considered professional codes. In the 18th century, the concept of medicine as a profession was established, and those individuals that influenced that greatly were John Gregory Scott and Thomas Percival. And before Gregory's time, physicians employed the term profession to distinguish themselves from surgeons or apothecaries who were regarded of a lower order than a regular physician. Gregory's writings were based on the Hume principle of sympathy, and that actually was a vital shift in the emphasis and orientation, and it went away from the physician and towards the patient. Gregory and Percival were the first to use the word patient instead of the sick, and Gregory's principle emphasized scientific clinical competence. It cautioned against the physician's self-interest and introduced the notion of medicine as a public trust as opposed to a merchant guild. Percival introduced the term medical ethics and employed it in his examination of physician conduct in hospitals and charities and with respect to the professional etiquette. So as we look through the 1800s, you look on the agenda of the American Medical Association, you saw in 1847 the Code of Ethics was on their agenda. And then recently, in response to many, many social forces and challenges, there's been an effort by an awful lot of institutions to have a look at professionalism and see whether it meets our needs today. So the list, it's hard to see. American Board of Internal Medicine did a project on professionalism. Charter on Medical Professionalism was a joint between the Americans and the European medical organizations. The physician charter that you recall from the cruises, the Royal College of Physicians of the UK did a huge study called Doctors in Society, and our own certifying bodies, the Royal College of Physicians and Surgeons and the Family Practice, Canadian Family Practice. So what makes you a professional? Is it just a set of skills like a hockey player or a carpenter? No. Is it a unique body of knowledge like an electrician or a plumber? Not necessarily. So when we look at what's unique in medicine, it's more than the knowledge, it's about the context and the judgment that you have to use with that knowledge. It's more than the technical skills, it's when to know how to use those skills and when they're appropriate to use. And it's the belief that advice given by a physician can rise above the self-interest. And if you encompass it, it's the unique relationship of trust with the most personal of information and circumstances concerning patients. So this is just another way of saying it. It's much more than the knowledge and the skills, attitudes and actions. It's about relationships. And if you've ever read some poetry, there's a good poet, a New Zealand general practitioner called Glenn Calhoun. He has a book called Playing God, very interesting poetry. And this is his words. It's about being in the red-hot zone of another's life. So what's changed in the world when we look around? Pretty well everything. It's the age of information. It's the age of increase in technology, science, technical capacity, global mobility. We now have foreign patients along with foreign doctors providing care. And we have generational expectations. We have differences in Gen X and Gen Y coming on board. So I guess I ask the question, why are we always surprised that changes and challenges have come to medicine and medical professionalism when changes have come to the entire world? So when we look at and break it down into challenges, you can see the external ones, commercialism, consumerism, increased bureaucratization, industrialization. And internally, we struggle with failures to uphold ethics or clinical autonomy questions or concerns about self-regulation. So if you look at commercialism, there's no doubt that healthcare is a huge industry. When you look around, oftentimes in some of our towns and cities, the smaller ones, it's the biggest employer. Professionalism's ethic of service is considered at odds with that of the market, of self-interest. So that's where the tension happens. It's a threat to individual physicians, but it's also a threat to the profession as a whole. And you can distill it down to it's really about conflict of interest. So risk to professionalism in Saskatchewan, this is what we've seen in Saskatchewan. We see partnerships with industry more than ever. We have practices located in commercial venues now. We have practices owned by non-physicians, large companies, some of the pharmaceutical companies, some of the grocery chains. We have increased privatization. Non-hospital treatment facilities are privately owned. And as we know, when something is privately owned, there needs to be a profit. Otherwise, these people, they're not in it to be benevolent, they're in it to make a profit. And we see the advent of what we consider entrepreneurial practices, that there's more and more push to go into boutique practices that offer limited treatments, medical spa treatments, Botox, things that aren't in the normal realm of medicine that they were trained for. And we sometimes see inflated charges for the completion of forms that aren't insured, such as the medical marijuana access forms, which are soon to be no more. That's the basis of a whole other talk. So the question is, why is commercialism incompatible with professionalism? And I think G. Hearn says it the most succinctly, that it's important, indeed imperative, for doctors to recognize that what they have is not just a market relationship or a trade union deal with the rest of society, but a very special moral contract. And if this contract is blemished or broken, not only is the public confidence and common esteem for medical profession sapped, but it will also infect and consume the self-esteem and moral habits of the practitioners themselves. And I think we've all had instances where we look off to the right or the left and we see colleagues doing things and you get frustrated thinking, well, why would they do that? And you see them benefit from it and you second guess yourself sometimes and say, why am I not doing it? Consumerism. Extremes of consumerism can pose problems. However, this is a correction to what we used to have, which was medical paternalism. Physicians would make decisions in the best interests of patients, but on behalf of patients, whereas now we have patient involvement in care. But extremes can pose problems. There's a proliferation of information out there that your patients access, and oftentimes they have access to either information that's not quite accurate or it's poorly understood, and sometimes it is very difficult for physicians to be respectful of the patient's need to look for information, but in a very short time frame in which you have to interact with patients, it's very difficult to get them to understand where the best information comes from. In Saskatchewan, we've seen an increase. Patients are accessing more information, and those that practice here will tell you that. They're demanding access to certain things, and probably the most recent example is the liberation therapy or follow-up surveillance when they've had liberation therapy, and they're now they're wanting to access ultrasound to see how they're doing with it. And Phenomenon is a company in town. I don't know much about it. It's up at the Research Innovation Place. My understanding is that there's a new gene testing for colon cancer. The problem that might pose for physicians is we don't know the veracity of that testing and where it fits into our system. So if a patient goes for it, pays for the test, gets the result, and it indicates they might be at a higher risk, we're not certain as to what physicians will be able to give them. Should they go ahead and do a FIT test? Does this bypass the FIT test and allow them access to colonoscopy? All those things have to be worked out. But again, it's this increase in consumerism. I, as a patient, have a right to go and get X. Sometimes I pay for it myself. Sometimes I get it through my physician. The flip side of that, of course, is when they're interested in their care, self-management is a very good option for patients as well. Increased bureaucracy. There's had to be an introduction of layers of management and policy directives between the physician and the patient. In the old days, depending on how old you were, there were very few levels in between. The relationship between your patient and you was the main thing. You didn't need a lot of access to anything else. We couldn't cure an awful lot of patients in those days. We provided compassionate care. Now we're seeing that care is much more than the relationship between the patient and the physician, and that there has necessarily been a result of increased organization to allow the delivery of the care. So there's increased complexity of medicine, but there's also involvement of government in all aspects of healthcare as they're the funders. Individuals have moved beyond individual practices to healthcare centers, to regional health facilities, to tertiary care. In Saskatchewan, we've seen an increased complexity. Our ministry is our funder, but our regional health authorities are those that hold the money in order to provide the service to their individual populations. Regulatory bodies like myself, we are doing licensing, standard and discipline, which is our normal business, but we're also being asked to look at quality assurance and quality improvement and a number of other things. In this province, we have a privacy commissioner and an ombudsman, but in other provinces, they have things called fairness commissioners who will review decisions that you've made in terms of either licensing or not licensing somebody. And in at least 3 provinces now, there's something called the Health Professions Legislation, which is an overarching legislation that brings in line all of the regulated health professions, and they determine the manner in which you will do your business. So I would not, if we had that legislation here, I would not have the ability to be flexible in the review of a complaint. I'd either have to look at it and kick it out saying, no, there's nothing with this complaint, or put it through a very formal investigation process. There's increased complexity in practice. There's multiple service delivery options. And like I've said, we've gone from solo to group practices and the regional health authority structures for diagnostics and investigations. And then there's, of course, many payment options, which again is another overlay. Industrialization. In one way, industrialization really is the elimination of variation in excess waste. That's seen as a reduction to costs. It's also seen as a bit of a risk to clinical autonomy, which physicians are holding on to. Some physicians have used this language: I feel like I'm a cog in an assembly line of care, and that if I don't have clinical autonomy to make the best decision I can for that patient, patient care will be compromised. The flip side of that is, though, if the variation is for no good reason, and it's only because that's how I was taught to do it, then maybe I'm contributing to the increased variation without having evidence base for that, and therefore it might be increasing the costs or decreasing the access because I'm wasting. So in Saskatchewan, we are undergoing a health system transformation at the present time with the use of lean, which is the Toyota model, which is basically to get rid of the waste in the system. And then the strategy deployment, they use, again, Japanese language called Hoshin Kanri. Basically really it's a structure of how you organize things. So one could see the health transformation as an effort to industrialize, but the flip side of that again is it's also an effort to increase efficiency and decrease waste in the system. And those of us that have practiced in the system for a long time all have examples of waste. Probably the one that used to frustrate me the most was I would spend an incredible amount of time writing a very detailed consult letter and appending a copy of all the test results to find out that the consultant obviously didn't look at my letter and just repeated everything anyways. So that all costs. So I question, in a system where we have few physician caregivers and a demand greater than what we have the capacity, is this not desirable? And the jury's still out. It's a project in process. Internal challenges, failures to uphold the ethic of service. We have physicians, unfortunately, who have been charged with abusing their patients sexually or financially. We have physicians who have sometimes health issues that have impacted on patient care. We try and work with a medical model for those physicians. But we also have the ongoing tensions about accepting gifts and what can you accept, what can't you accept. Job action. Clinical autonomy, I've mentioned. If it's for unilateral decision making instead of appropriate use for the patient, it probably is something that we need to get rid of. However, if a certain amount of autonomy allows you to do what you think is best for your patient, then that's the good side of it. You're doing it for the best. But widespread variations in treatment patterns may actually waste scarce resources, and there's more and more literature coming out. So we have to be careful what we want to hang on to. Self-regulation, thought by some to be very weak, and from a public perspective, oftentimes seen as more in the interests of the physician. From the physician's perspective, it's seen in the interest of only the public, and they never listen to us and they never take us into consideration. So there's that tension. So a new way of defining it, what should be retained? There's a lot of work being done in the UK, and they looked at things like knowledge, skills, science, practice, profession. All those things are good. There was an incredible number of people who thought it was a vocation. Some thought it was a calling. And then appropriate accountability, because now we're having to work in teams. You can't expect a physician to work in a team and then be the only one accountable for what happens. So I think things like this are important improvements in defining professionalism. Altruism, on one hand, it suggests unselfishness, but it can be interpreted sometimes as being morally better. So we have to be careful how we use it. Again, more words that can be misinterpreted. Mastery suggests a skillful use of body, or body of knowledge, but can also suggest control, authority, power. Autonomy, same thing, might suggest the physician has the right to act independent of both the wishes of the patient and best practice. Privilege can be interpreted as a special freedom or immunity from. And self-regulation, we now prefer to call it professionally led regulation because we have public members involved. So modernize the concepts. We want to make sure that competence means ability or capacity. Should we not strive for excellence? The art of medicine, don't we really mean judgment? And the social contract, really that should be changed to what's more defined as a moral contract. It's an ethical edge to a mutual agreement. So what needs to be strengthened to be relevant? So the partnership with the patient. Patient outcomes. Oftentimes we don't focus on the well-being of the holistic notion of the patient. And it's the physical, mental, social aspects. It's preserving human dignity and making sure that we have a purpose to protect, restore, and strengthen human well-being and dignity. Because without purpose, medicine can erode to technical exercise of disease management devoid of human empathy and compassion. So Doctors in Society, and I'm just going to flip through these because you can look it up if you're interested, but they provided a different interpretation, and I think they got closer to what we really want today. So it signifies a set of values, behaviors, relationships that underpin the trust the public has in doctors. And it's a vocation in which a doctor's knowledge, clinical skills, and judgment are put to the service of protecting and restoring the human well-being. And this purpose is realized through a partnership between patients and doctors, mutual respect, individual responsibility, appropriate accountability. And then they have the list of the normal values. And then these values, which underpin the science and practice, form the basis of a moral contract between the medical profession and society. And each party has a duty to work to strengthen the system of the healthcare in which our collective human dignity depends. So who cares? When you look at the literature, it's very surprising, actually. In that particular study, they went to thousands of physicians in the UK, and they went to 2,000 trainees. And it wasn't just patients that cared. It was physicians, the trainees, the professional societies, the health institutions, regulators like me, ministries of health, and the funders. So how do we promote it? We've modernized the definition, but what we have to do when we're shifting towards another service delivery, we have to strengthen the leadership. Physicians need to be involved in the development of healthy public policy. Leadership should encompass the individual, but also the clinical team, the regional teams, provincial and national strategies, because all of those decisions impact on what you can provide to your patients and how you can provide it. Strengthen teams. We've got to learn lessons from our colleagues who've worked in teams for a long time. The qualities of a professional are about making sure the team works effectively despite difficulties, but it also requires a supportive healthcare system, and that's the piece we're having to work on right now. If we have to make this change, we can't make it independent of everybody else. We need to strengthen education. How often are medical students trained with nurses, trained with pharmacists, trained with, you name it? They're not. They're still in silos. There's some movement towards training them together, but it's not good enough yet. We need to be prepared for the system we'll work in, and that's to train with others. We also would have to assist those physicians that have been encultured in the old professionalism like me and get them up to date. And that might require career development, a means of ensuring that they can identify a new career path as they go through their careers, allowing changes, promoting ongoing professional learning needs. That's one of the biggest things. Lifelong learning is imperative, and it needs to be emphasized. And that includes the IT world, which is very strange to a lot of us that were not brought up with computers. Recognize the responsibility to be involved in professionally led regulation. And this will come in this province with requests to assist with assessment of colleagues who don't meet the normal registration practices and have to be assessed, and also assist with the governance of the self-regulation. Plan for the workforce changes. We've heard about the shift in gender. We're seeing more females in medicine. That will require us to be sensitive that they need periods of time out if they wish to raise a family. And we need to plan for the Generation X and Y expectations. We need to replace them with more. They're not willing to work the same length of hours we are. And we need to plan for more practice interruptions. Gen X makes lots of changes in their practice location. Gen Y wants an employment model, and we're not there yet. We need to support physicians through the physician health programs. We have to make sure that we're well when we enter medicine, we stay well as we train, and we're well as we practice. And those are big struggles. Physicians are not immune to disease. Who should promote it? I'm suggesting we don't wait for others. If we do, they'll change it for us and we won't like it. And you can't rely on regulation. Sometimes people will say, well, that sounds like regulation, we'll just let the college handle that. Professionally led regulation needs to do its work and be seen to be doing its work, but it would be a huge step backwards to go to a rule book. You can't codify things in medicine. As individuals, we need to ensure that we contribute to the ongoing relevance and importance of medical professionalism, and I believe that there's no one better than you to do it. This is Ageless Wisdom. The last one, both of them are William Osler. They could have been written today, basically. The practice of medicine is not a business and can never be one. Our fellow creatures cannot be dealt with as a man deals in corn and coal. The human heart by which we live must control our profession. So my summary is we must rigorously promote and practice professional medicine today. And we must do it by, that should not be heatedly, that's a Freudian slip, wholeheartedly resist and reject the influence of business. And I think we also have to look at the other part that makes you different from other professionals. You need to cherish and protect that relationship that provides us the opportunity, as Glenn Calhoun says, to stand inside that red-hot zone of another human being. Thank you.
Thank you, Karen. Are there any questions from anyone? Okay,
good. There's a new concept in the financial community which is being hotly debated, which is that the interests of the customer should come before the interests of the advisor. And I think that putting our patients' interests before our own is the essence of professionalism. These people are not yet professionals. So we're under pressure to put the interests of the system ahead of those of our patients. And I think that's just as much a threat to professionalism as is avarice. We're under pressure, too, from some ethicists who support things like denial of care the system can't provide and ensuring that it can't be provided by dredging up the principle of distributive justice. These people are a threat to professionalism. Any comments?
Well, I mean, I think you're quite right. In this province, we have had, I think, the good fortune of having the Patient First report commissioned. It was an opportunity for patients to stand up and say actually what they wanted, what meant something to them, what was most important to them. I don't think prior to that there was ever any opportunity. I mean, quite often it was filtered through us. I think my patients want X. I think my patients want Y. There wasn't really a forum in which they could say what they wanted. And what they wanted was pretty basic. They wanted a relationship with the patient. They wanted to be heard. They wanted access to the system in a timely fashion. Nothing was really outrageous. I mean, some of the things that were a bit of a disappointment to us was the emphasis on surgical access, because we knew that there was a number of other very important areas like mental health and addictions where access was pretty poor. But you have to start with one thing. I think you're quite right. When people pull one piece out and say that's the problem, I'm not certain that it's helpful to us to look at it in pieces. I think threats come from a lot of corners. And I think that the average physician today has a tough job in balancing what's right for their patient, making sure it's not too much, that they're not advocating for something that isn't evidence-based and might actually be disadvantaging the next patient, but also having the balance between, is this a reasonable service for the time I'm being paid for it? Because there is the business of medicine. You have to be paid well for what you do, and you have to balance that. The trouble is, I think in this case, is as we're moving to a population of people who want an employment model, my concern is that that employment model takes them one step away from the patient. And I think that's a bigger risk as we go forward, that they won't see it as their duty to stand up for the patient necessarily, and that they'll say, well, it's not really a problem, I'm not in conflict, I just get paid a salary. But all those things still exist. So I think you've raised some really good points. I don't have any answers. We struggle with these things on an individual basis. We struggle with them at the college on a case-by-case basis. But I think if we can just keep our eye on where we want to go, it's probably, it'll probably take a lot more of us to get to the right balance. Anything else? Thank you very much.